Good afternoon. My name is Tia Teriak, and I'm very happy to welcome you to Concord Hospital Trust's What's Up Doc Donor Lecture Series. Our presentation today is, when is a pinch a good thing? And that's when it closes a leaky heart valve with the MitraClip. Our guest physician today is Dr. Shahab Moossavi from the Concord Hospital Cardiovascular Institute. Dr. Moossavi attended Mashhad University of Medical Sciences. He completed his residency at the Bowman Gray School of Medicine of Wake Forest University, and he completed 2 fellowships at the University of Vermont College of Medicine. Dr. Moossavi is board certified in cardiovascular disease, internal medicine, interventional cardiology, and endovascular medicine. Dr. Moossavi joined the Concord Hospital in 2016. His current focus is high-risk coronary intervention, aortic and mitral valve cases, and mechanical circulatory support. Dr. Moossavi and his wife have a 2-year-old and are expecting their second child at the end of April. Please join me in welcoming Dr. Moossavi.
Thank you. Thank you, Tia, for the introduction. Thank you for the opportunity to talk about one of the procedures we offer in Concord Hospital. And thank you for our audiences that they are available online. I chose this slide set from Abbott, which is a company that makes MitraClip, and it has been used for educational lectures across the country, and they have had good reviews, so I think that's a good slide set to use. What it really does is actually it changes the course of patients that they have a heart failure condition. To bring you up to speed about mitral regurgitation, it basically comes in 2 types to be aware of. If you think about any condition, it comes with primary mitral regurgitation or secondary mitral regurgitation. And if you think about it, easy way to remember is the primary is a condition that the valve itself is the problem. The secondary is the valve is doing okay, but the result of another condition that is affecting the valve. In a nutshell, if you have, for example, think about if you have a structure at home, your door is broken, then the mitral valve would be your door, and that would be the primary. The secondary is if you have a crack in the wall and the door doesn't close good enough, then that would be the secondary because the valve is affected because of another problem. Moving forward with basically patients with heart failure is a fairly common problem across the United States, as well as actually across the globe if you think about the heart failure patients. And if you think about it, 1 out of 5 patients that they have heart failure, they have degree of mitral regurgitation. That would be an overwhelming number of patients across the country, as well as across our state, that they are suffering from the heart failure, and 1 in 5 of them has mitral regurgitation. Many of them are secondary MR. Why is it important? Because the mitral regurgitation threatens the patient's survival. If you think about for those patients that they are symptomatic, they can have as high as about 57%, roughly about 60%, roughly about 6 in 10 patients, they can be threatened. It's a cycle that basically starts from the mitral regurgitation. What it does, it can increase the load and the stress on the heart muscle. It can eventually cause damage or loss to the heart muscle. As a result, it can affect the function of the pump of the heart. It can make the pump get worse, and this cycle continues to make the mitral regurgitation worse, and eventually it can lead to patients' deaths. It can predict the prognosis on the heart failure patients. This is a nice graph that you follow. On one line you have basically the time, on the other line you have the degree of mortality, and it kind of separates in different color to kind of assess. Those patients that they have less regurgitation or leakage, they are on green, a little bit more, they are on blue, and worse, they are on red. If you see, even from the get-go, when they are diagnosed, the line starts to separate. For severe patients, you can see this separation at 6 months. You can see the separation worse at 12, and by 2 years from the time of diagnosis, you might have a mortality as high as 60 to 70% for those patients that they have mitral regurgitation. So it's a serious condition, and without the treatment, the patient's prognosis is not good. It is important because it used to be thought that it's a treatable condition, medication that do the job. Having said that, on a longitudinal follow-up with these patients, they recognize that the gravity, once they have heart failure, once they have severe MR, is not so good. If you think about, compared to cancer, for example, there are patients even with lung cancer, with current treatments, they can be around beyond 5 years. With this condition, with heart failure, the prognosis is not so good, especially if they have mitral regurgitation and if that is not being treated. Now, we have a little bit of background why this condition is important. Number one, to pay attention, and number two, how it's going to be affected if you don't treat it. We want to touch base about the treatment that we are offering these patients. If you think about the heart failure and the medical management, if it was sufficient to prevent mortality and hospitalization, that would have been fantastic. Having said that, it turned out to be, even with maximally treated medical therapies, these patients, they don't do very well. Surgery is a good option. Not every patient can tolerate it. It comes back to MitraClip. This is basically the shape of the device eventually once it is delivered. And this picture depicts actually how does it look like. It's proven, approved by FDA for the patients with mitral regurgitation. In fact, as of now that we are talking, it's approved for both primary and secondary patients with heart failure that they have been on goal-directed medical therapy. And you hear it a ton in cardiology community, GDMT, that basically stands for guideline-directed medical therapy. So you do your treatment, you don't make headways, then you consider about the treatment option. This is like how it comes from the company. It's on a delivery system that basically you can deliver the clip for your mitral procedure. It's minimally invasive. If you think about it, it doesn't require an open chest. You can see as you are putting the clip with the echo probe that you have it through the foot pipe, the reduction in your mitral regurgitation. You have the opportunity to reposition the clip before you deploy it, which is the beauty of this device, because if you are not happy with the area that you are placing, you can grab it, start over, put it in a spot that you like, make the patient's mitral regurgitation get better, and deploy it. On average, the length of hospital stay for these patients is between 2 and 3 days. And that is also important because some of these patients, they are more advanced in age. Some of them, with the social support, some of them being away from the family, friends, kids, pets, all those things that they are being important in evaluating these patients, a fairly short length of a stay on average. This kind of like walks you through what you're looking at. You're looking at a echocardiogram which being done for the procedure through the food pipe. We have a imaging cardiologist that is equally involved for the procedure for every case, and we start the procedure. What you're looking at, the echo probe actually looks from back of the throat and back of the food pipe. The upper chamber here is the left atrium. The bottom chamber is the pump. You have your mitral valve here, and what you see here is a regurgitation jet that you see over. Once the clip is here, it brings these two together. As a result, the regurgitation jet is much smaller, and you can see it in real time before you deploy it. This kind of picture, the cartoon, walks you through what we do. The way that we do the procedure, the patient comes in the morning, we prepare for getting access to the groin. We use the vein through the groin. We bring our catheter up. We cross the upper chambers of the heart. Again, to orient you, this is right side, this is left side. Come through the vein, crossing the upper chambers from the right to the left. Bring the clip on top of the valve and orient the clip the way that we like it. Bring it down. If you think about the valve, the mitral valve is like a, for lack of a better term, it's like a D shape or an O shape type of thing. And once you put this clip in, you change it from that O or a D shape to a figure 8 shape. As a result, the regurgitant jet or the leakage is smaller, and as a result, you improve the patient's condition and the patient feel better. What is nice about this procedure is before you deploy the clip, you still have it on your delivery system, and I have my echocardiologist that can tell me if we are happy with improvement on the regurgitation, and also assess the patient's vitals and hemodynamics. If there is, for example, a stenosis, which can occasionally happen with this procedure, the echocardiologist can tell me, and we can reassess, we can modify it, we can move it from side to side, and change the orientation of the clip. Once we are happy, then we release it. This V shape stays over there, and the delivery system comes out. Kind of closer look on the device. What you see basically is a V shape. They come in several different sizes. It has a arm here that before we deploy it, we attach it to the leaflets of the valve, and once we are happy, we release it. It stays over there. If you think about this, there is years and years of data behind this procedure. In fact, it has started from the surgeons back in the day, several years ago, or actually decades ago. They started this procedure with the surgery with just putting a stitch over there. Having said that, the echocardiogram was not as good as it is today. The clip is a different mechanism as opposed to a suture. But that idea kind of inspired to have this clip. It started in early 2000s. It started with several randomized trials. In Europe, it was approved as of 2008 to basically use this procedure. In the United States, FDA requires us to have more data, and as a result, a couple of more trials happened, as well as following up with the European patient population. And finally, FDA approved this procedure for us in 2013. Continuation of collecting the data, and thereafter it commercially becomes more available. And again, after the FDA approved for the primary, they approved it for secondary in 2019. And we are fortunate in Concord Hospital that we have started this procedure in late 2020 to offer our patients. Again, the data is vast, more than 30,000 patients in clinical studies and much more in the real life. Several randomized trials, and those are the guideline-directed studies that basically gives us the data that we need to offer these patients this treatment. One of the landmarks in our interventional cardiology literature and the structural cardiology is worth to mention was the CORD study. That was basically a one-to-one randomized study. They received the goal-directed medical therapy, or they received the goal-directed medical therapy and MitraClip. Multi-center study was done. It published basically in New England Journal of Medicine, which is probably as good as you can get for any study for publication, and basically validates the quality of the study as well as the structure it was performed across the country. That result was basically significant. Those patients that they were in the arm that they received the MitraClip and goal-directed medical therapy, they improved, and that validated the treatment. It met all the primary endpoints, both in terms of effectiveness and in terms of safety. Safety was defined as freedom from any device-related complication within a year, which is fairly significant, and effectiveness was basically within the first 24 months. If you think about that, 24 months was chosen based on the graph I showed you guys earlier, that was showing how the red line kept dropping over a number of years, and that was important to prove those patients continue to do good with this treatment. They followed up with these patients at 3 years, and even you can see at 3 years, this is again the graph that shows the mortality. The higher the worse. This shows the longitudinal in terms of the months of follow-up up to 3 years. And you can see, you saw the separation fairly early by 6 months, and that continued to be separated over time as they followed with the patient. If you kind of roughly follow up, this one is less than 30%. This one is about 55 to 60%. You have a nice separation over time between these patients. This number from a statistician as well as from me, if I talk with my patients in the clinic, is important. This 7.9, and I'm going to get to it in a second, why this number needed to treat is important. If you think about, you offer the patients the treatments, what it means basically, number needed to treat means how many patients you need to treat to prevent one death. And why is it this number is so significant is because, you know, you watch a TV ad about Entresto. You use this medication, you need to treat 40 patients to get one benefit out of those 40 that you're treating in terms of the mortality prevention. Now, I'm not talking about the symptoms, I'm talking about the mortality. You need to put 10 patients through the cardiac resynchronization therapy, which is offered by my electrophysiologist partners. Out of 10, you have one death prevention within 29 months. If you treat 7.9 or 8 patients, you're going to prevent one death within the next 22 months, which is significant. And in fact, it's one of the probably cornerstones of this treatment, how it can change the patient's quality of life, how it can prevent deaths in a very small amount of patients that you treat in terms of seeing the benefit. This is also another slide from the study. It's a busier slide, and in a nutshell, what you're looking at, the 4+ is the worst type of regurgitation you can see. Less than 1+ is minimal. So if you think about this dark bar is very small regurgitation. The gray bar is significant regurgitation. With the goal-directed medical therapy, when you take a look, you have mostly the colors that signifies significant regurgitation, which is not generally speaking a good thing to see, which basically indicates that with goal-directed medical therapy, you are not really changing the course for the mitral regurgitation. What you are achieving is mostly symptom relief, and of course, it doesn't treat the condition. With the MitraClip, you have started at baseline with the colors that signifies significant regurgitation, and over the course of time, you see how that regurgitation or leakage improved, and it stayed about the same, which is the reason that bar showed you see benefit in terms of mortality compared to medical therapy only. It also improved the quality of life, and again, they had a comparison between the control group as well as the device group, and they noticed benefit in terms of quality of life. In fact, they managed to find that 2.5 times more likely to experience large improvement in quality of life with this treatment. It also reduced the risk of heart failure hospitalization by more than half. If you think about like in all the different regulatory agencies, they want to see us, we have less admission for heart failure, we can treat the patients, keep them out of the hospital. We have fairly active heart failure team and clinic. We have one of our general cardiologists most recently joined us, and she's running the heart failure program. And I'm optimistic we can expand over time with our heart failure patients to prevent these patients to come back to the hospital. And of course, this is another tool in our toolbox to keep these patients out of the hospital. When you follow with these patients over the 3 years period, the number needed to treat was about 3 patients to keep one of them out of the hospital, which is again pretty significant. That number continued to be separated for those patients that they received intervention with MitraClip and goal-directed medical therapy, as opposed to goal-directed medical therapy only. So it improved more than half of those admissions. Now, it's a safe procedure. Again, like any invasive procedure, it comes with a risk. However, the risk is minimal. What they like to follow up, both based on the safety for the device as well as the regulatory standards, was to make sure you don't have much of complication. What are those complications? If you have, for example, that clip is only attached to 1 leaflet as opposed to 2, it was less than 1%. If you have device embolization, which means the device dislodged, again, it's less than 0.5%. If you have infection that requires surgery, in that study was none. If you have mitral stenosis, which means the other spectrum of mitral disease, they had none. And the reason behind it is because you have an echo probe through the foot pipe that the echocardiologist can tell you in real time if you are going to face that condition. Those patients that they became sick and they required some kind of pump support, were around 3 patients or 1.2%. Those patients that they required heart transplant, less than 1%. In fact, there was a study came around 3 months ago, and it was presented in a national meeting. Many of these patients that they received MitraClip, they were on the train for the heart transplant, and you were able to manage to push the transplant in a much later time. They could do better with their native heart, which is a very satisfying thing to tell to the patient. Any device-related complication with non-elective cardiovascular surgery, again, was less than 0.5%. The numbers that we quote to the patients in terms of the freedom from all-cause mortality, etc., those are the numbers that we discussed with the patient in the clinic, and the follow-up with the patients, you can see it on this bar. The data from another study basically showed continued trend in low mortality rates compared to prior registries. And these are the different registries that they have been keeping for the Everest, for the European studies, for the TRAMI, TVT, which is the registry for the valves, and the expand. And all these numbers, if you look on this graph, is fairly limited with less than early days 6%, nowadays less than 1.5%. After the MitraClip procedures, patients are out of the hospital, again within 2 to 3 days on average. 9 out of 10 patients are discharged to home as opposed to going to a rehab center or assisted living facility, etc. Patient reported sustained improvements in their quality of life. In fact, for these patients in the clinic, we have our route coordinator and our clinical staff. They do assessment with the quality of life questionnaire. They walk them the 6-minute walk before the procedure and after the procedure and follow-up. So we have something to compare, and it's not only what do I feel, it's actually you can document it based on how the patient did over a period of time. It's well established with clinical history. There's more than 30,000 patients in the studies. Across the world, more than 100,000 patients have received this treatment. More than 16 years of experience since the day that this treatment was introduced to our specialty, and 96% plus freedom from device-related complication at 12 months that it was seen. So how we can help with our heart failure patients with mitral regurgitation? I think it really comes to multiple things to be done. It really comes from literally everybody, from the nursing staff that they see those patients at the bedside in the hospital, from the primary care that they have the closest relation in terms of providers with the patient, from the cardiologists, from even the family and friends that they see these patients that they are huffing and puffing, from us as providers to think about it and have an open eye about the treatments that are available for these patients. Again, if you think about it, you have about 1 in 5 or 20% of patients with heart failure that they have this condition. It's the reality that unfortunately the medication, they do not work. With only medications, you can only see these patients that the number they shrink over time, and there should be a better treatment. This MitraClip procedure for those patients, it serves them for 2 goals. It can give them a better quality of life, and hopefully it can give them more years of life without hospitalizations. When it's used with maximally tolerated low-directed medical therapy, for those patients that they have, again, moderate to severe or severe mitral regurgitation, these are the patients that they are benefiting from the treatment. They should have that grading for the mitral regurgitation, which should be more than 3, or moderate to severe. As we talked, their heart muscle, the pump should be anywhere from 20 to 50%. And think about the normal range is usually 55 to 60%. We don't want to have their left ventricle to be too dilated because it can affect the procedural success. The cut point for that is less than 70 mm, which is roughly less than 3 inches in terms of dilatation. And of course, they need to have the symptoms. At the end of the day, you offer a treatment to a patient to make their symptoms get better. So if they are symptomatic. Check your heart failure patients for one or more of these symptoms. It's really, I guess, important to think about it. These heart failure patients, not all of them comes with shortness of breath. Sometimes they have limitations in physical activity. Sometimes fatigue. It's so easy to see the patient, and the patients complain of fatigue. You tell them that it's aging. But sometimes there is other reasons behind it. If they have a recent echocardiogram, look on the echocardiogram. Maybe they have heart failure, maybe they have mitral regurgitation. That is the reason that they are fatigued, not necessarily just a process of aging. If they are gaining weight, that basically means they are doing volume retention. That can be another symptom. If they have edema, which basically means fluid retention, either in the lower extremity or in their belly, that can be another symptom. Sometimes I ask my patients that how are you feeling compared to 6 months ago? That is a very good way to assess it. If the patient says, yeah, I mean 6 months ago I could walk around the aisle in the grocery store, now I need to stop 2 times to catch my breath. That tells me, even though if the patient is not telling me that I am getting short of breath with activity, they are recognizing that there is a change in their functional status, and that can be a good way to elicit the information from the patient. The echocardiogram, of course, is a standard for detecting this condition, and usually it starts with a surface echo. And we have actually a heart meeting in Concord Hospital. We have started the heart team meeting on a regular basis since we introduced the TAVR, which is the transcatheter aortic valve replacement. Our heart team actually has expanded nicely. We do one meeting every Tuesday of the week from 4 to 5 p.m. Pretty much anybody who is involved in that particular patient is welcome to come, but generally speaking is HIPAA protected. It includes 2 cardiac surgeons, 2 or 3 interventional cardiologists, cardiac imaging. We welcome anesthesiologists, and again the primary care, and anybody who has clinical relation with the patient to attend. We discuss about all these patients. We think carefully about the patients, that they will benefit from the treatment, and once this is approved, which treatment to offer to the patient, we move forward. We have a dedicated valve coordinator that she is extremely busy. In fact, last year, based on the U.S. News report, Concord Hospital was the 2nd hospital across the state in terms of our TAVR, or transcatheter aortic valve results, which with the exception of academic center, we are the best community hospital that offers that treatment. So definitely it has kept us busy. Discussing about the MitraClip with your heart failure patients, again with mitral condition, the medication can help the symptoms, but it doesn't resolve the underlying problem. Surgery is still the gold standard. Having said that, not every patient can tolerate the surgery, and MitraClip is a minimally invasive procedure that effectively can treat this condition, the patients that they have heart failure. So in summary, with the co-op trial that we talked about it can save lives over the number of months that the patients have been followed with. It can improve the risk of rehospitalization. And none of the patients, they want to be in the hospital, and that's the reality. So it's the second best thing that can offer to the patient. It can also improve their quality of life in terms of their symptom relief. So what we want to do, we have the representatives from the ABA that actually are equally involved for this procedure. This is basically their safety data that is more about like the details of how to use the device, what to do with it, what are the indications, what are the contraindications that of course needs to be disclosed to the patient. That's pretty much about it in terms of the procedure that we offer and in terms of the benefits of this procedure for the patients. I would like to open the conversation now to ask any questions. Sure. Go ahead.
I have a couple. The first is, does it need to be replaced over time? I guess with only 16 years, you may not know that.
Right.
But does it like, does it kind of run out of its whatever, its effectiveness?
Right. So the question is that does this need to be replaced? And that's a good question. The answer is no. This is different from the valve replacement. Historically, if the patients are receiving a bioprosthetic tissue valve, those they have a longevity of 10 to 15 years on average. Those they need to be replaced, for example, for the transcatheter aortic valve. For this condition, the clip stays there as long as the patient is alive. If the condition gets worse, we can put a second clip if they need it down the road. Sometimes it also makes the patient feel better, so they can, down the road, if they need it, they can undergo an open procedure, or if they require to have a transplant, they can go receive their transplant. But the answer is no, not necessarily.
Can a cardiac surgery create the secondary MR? I know that's
So, yeah, I know. So the question is if cardiac surgery can. That's a good question. The answer is no. The cardiac surgery sometimes, if the surgeon repairs the mitral valve, it can happen again over time that the mitral valve gets worse, and then they need to have a clip procedure. If the mitral valve is replaced with the surgery, if it is a mechanical, then the answer is no, because mechanical valves, they are supposed to stay and last forever as long as the patient is on blood thinner medication. The tissue valves, they can fail based on what we talked about in 10-15 years. And if they require, there are treatment options, transcatheter, with putting another valve through the surgical valve. Those are more compassionate use, and they are not streamlined yet. But we have limited experience in Concord Hospital. For the valve-in-valve, they do better if they need a transcatheter treatment.
Are there any other questions? Okay, I have one more. Do you place more than one? Do you ever have occasion to place more than one clip?
That's a very good question, actually, and in fact we do. As long as, so remember how we have the echocardiogram? Well, the question is, for those that they cannot hear it, do you need to put more than one clip? It actually is a very good question. In fact, we have the echocardiogram through the food pipe, and remember what I was talking about, that we have the echocardiologist for the entire case. That person happens to be Dr. Weeks, one of my partners, tells me during the procedure if we still have significant mitral regurgitation. If there is a still significant mitral regurgitation, we end up to put a second one. If you still have it, you can put a third one. The fourth one hasn't happened to us yet. The most that we had, we put 3 on a patient that had one done in another institution, and he still had mitral regurgitation, and we ended up to put 2 more, and that patient did well. I have talked with my friends from another institutions, not inside the state, that they have patients that they have put 4, but those are extremely rare. And of course, for the patient, it's important if they receive 1 or 3 clips, the cost is about the same. The procedure is about the same. What we do, we only assess to make sure we start from severe, we go down to mild to moderate before the patient comes off the table. Sure.
What symptoms is a patient showing that would make you even do an echocardiogram in the first place? Because when I looked at the symptoms of the MR, I'm like, gosh, that could be so many different things.
True. That's a good question. The symptoms question, most of the time, I'm kind of like getting the referral from my general cardiologist. I'm not really the front line for particularly for that matter. Having said that, these are the patients that they come with garden variety of heart failure symptoms. Some of them, they are being admitted to the hospital by my hospitalist partner, and the patient that comes with heart failure, they get an echocardiogram for that admission. But generally speaking, usually they have the usual heart failure symptoms. They are short of breath, they are out of breath, they have chest pain on occasions, they have evidence of volume retention. Sometimes they can even have atrial fibrillation, and atrial fibrillation is not because of abnormal heart rhythm, it's because of their heart failure, it's because of the mitral regurgitation, it's because the upper chamber of the heart is getting so big, the electricity of the heart is not as good as it used to be, and now they have conduction problem. They have volume retention, lower extremity edema, they don't respond to diuretics that they used to respond. Those are usual symptoms, or they have decline in their exercise tolerance. They used to walk, 5 steps up, now they can go 2. They need to stop to catch their breath. Sometimes they have cardiac cachexia, which basically means the patient's weight is dropping over time, not because of they're not eating enough, because they don't feel to eat anymore, because of the wasting that they have because of advanced heart failure. So it's really a heterogeneous host of symptoms that they can have, and the one thing that they share, they have heart failure.
Questions? Thank you, Dr. Moossavi.
Oh, I appreciate it.
It is fabulous to know that this kind of technology and your expertise is available here at Concord Hospital. Thank you for your time and joining us for What's Up Doc today.
Thank you so much. Thank you. I appreciate it. Thank you.
And to everyone, we thank you for joining us today. I want to let you know our next What's Up Doc is Friday, March 12th. And Dr. Emis Kelmaki-Key from Concord Plastic Surgery will be our guest speaker. And her presentation is entitled Reconstructing Venous, the Birth of Breast Reconstruction After Mastectomy and Its Evolution Through the Ages. We hope you will join us. Please continue to stay safe and healthy, and we hope we are able to open up What's Up Doc to our valued donors and have you back in very, very soon. Take good care.